Good afternoon.
Good
For a
afternoon.
very brief overview, the Genetic Disease Screening Program, or GDSP, runs two programs, the Newborn Screening Program and the Prenatal Screening Program. The Newborn Screening Program screens just about every baby born in the state for 80 different genetic disorders. This is a mandatory program, so we only statute only allows parents to opt out of screening for religious reasons. There's no conscientious objection allowed. And all babies are screened usually prior to leaving the hospitals. We have special procedures for collecting home births, but most babies get it prior to leaving the hospital. It's a blood specimen that's taken from the heel, put on a filter paper card, dried, and sent to our regional laboratory. And what we're looking for is to identify babies who are at increased risk for a number of different disorders. And then those babies we identify as being at increased risk, we do additional confirmatory testing and diagnose them and make sure they are referred to special care treatment centers and placed on treatment so that they grow up normally. All of the disorders we screen for are things that don't show up at birth, so babies look normal, and you wouldn't be able to tell looking at them that there's something wrong until symptoms show up, and usually by the time symptoms show up, damage is already done. So it's important to identify them before those symptoms show up, get them on treatment, and allow them to grow up normally. The second program we run is a prenatal screening program. This is an optional or voluntary program. However, it is mandatory for prenatal care providers to provide women with information about it if she presents for his or her care prior to 20 weeks of pregnancy. So the doctor has to offer it. The patient doesn't have to participate. We have 500,000 babies born every year in California, and we screen all of them. We have about 360,000 women participate in the screening program. California has a unique screening program in that newborn screening is available in every single state of the country and in most developing countries. Prenatal screening is only a state program in 2 states, California and Iowa. And California is the only program that has a comprehensive program where you pay for the testing, but if you have a positive screen, your follow-up care is provided free of cost for that initial care. So for women who have a positive screen, they can go to one of our prenatal diagnosis center and receive follow-up services, genetic counseling, ultrasound, amniocentesis, diagnostic procedures in order to diagnose what their fetus might have. So those are the 2 programs we have. Our budget is just over $116 million. This year we estimate we're coming in $145 under budget. However, next fiscal year we are coming to you and asking for an increase in our appropriation of $2.5 million, and that's part of the budget change proposal that we'll discuss. Budget change proposal is, the $2.5 million is mostly for budget change proposal for 1559. There is $550,000 that is an increase to deal with caseload increase and a slight increase in the cost of care. But the bulk of it is $1.975 million for one position, and which is an ongoing position, so that's $150,000 that would be ongoing, and then $1.825 million one time to make mostly the programmatic and computer changes that are necessary in order to implement AB 1559. 1559 was passed last August and signed by the governor in September. It requires the department to add screening for the disorder adrenoleukodystrophy to our screening panel. Some of you may have seen that movie many, many years ago called Lorenzo's Oil. Deals with that disorder. ALD is a disorder that affects mostly boys, and it's one of those disorders that doesn't show up for many years. Most boys with ALD present at about 6 to 10. It's usually seems to be attention deficit disorder. It's initial cognitive kind of things. And by the time they've had a crisis and damage is done, they're beyond the point of treatment and care. So if they're identified early, and as soon as they start to show a symptom, and that symptom would be a change in a brain MRI, then they do a bone marrow transplant, and it ameliorates the symptoms. The disease doesn't progress anymore. It's not a cure, but it doesn't progress anymore, so these boys grow up normally. So we're very excited about that. However, the bill says that we will wait until ALD is added to the federal recommended uniform screening panel. Disorders get added to the panel. There's a federal committee that reports to the Secretary of Health and Human Services at the federal level. They review disorders for medical and testing ability, and then they look at public health ability. Are the public health programs and newborn screening programs around the country ready to add these? Is there follow-up testing? Can they diagnose babies or just do screening? What are all the different pieces? And then as it moves through these committees, it gets recommended to the secretary, and the secretary then makes a decision. So we're at an advantage that we can sit back and watch how it's progressing through these committees. They meet 3 times a year in February. They just met last month, May, and September. ALD has made it through the first committee, and it's passed the medical review, and it's been passed on to the public health review. We anticipate that the public health review will go through and be approved and pass on to the general committee for vote either in May or at their September meeting, and then be recommended to the secretary. That's the part that's more out of our control. She can sign it immediately. She can take as long as she wants to add it. Our thoughts are that it will probably be added after the September meeting, and that she won't take too long. That's what we hear. So, but our challenge is the way the language of the bill was written is as soon as it's added to the RUSP, we have to start screening for it. So we need to be prepared. We need to make the changes to our computer system and be ready to go. So we're coming to you and asking in the BCP for the money to make the changes to our system and that one staff person who will get us ramped up and ready to go with all the planning, with all the outreach to physicians, to be ready so that when it's added to the RUSP, we're ready to go.
What are the well, maybe we don't know. Is there a sense of numbers in California?
The incidence is expected to be 1 in 20,000 boys.
Got it. Okay. So, okay. Any questions, Senator Monty?
Quick question on the existing prenatal screen. At what stage of pregnancy can that be conducted? So
California has a very interesting program. We offer it for women in both the first and second trimesters, and we have women can participate in a number of different ways. So you can get a specimen in the first trimester, and you can go to a special ultrasound reading and have a special ultrasound reading taken. And the information from that ultrasound reading, along with your test result from first trimester, we can give you early information results. You can also come back in your second trimester and get more testing, and we combined it all together and give you an even higher level result. So women who get both the ultrasound and both trimester readings have an over 90% diagnosis rate for Down syndrome. So if the more you get, the better the risk assessment is.
And as I understood you, participation in that is voluntary.
It is voluntary.
But if there is any cause for concern,
it's voluntary as well. So women, if we come back and we say, your risk is 1 in 150, and by our cutoff, that's positive, and so we will pay for you to have follow-up services, women can say, thank you very much for that information, goodbye.
Right.
They don't have to participate.
Thank you, but my question really went in that second part,
Okay.
and you answered it. The services are there if they choose to access them.
They are there, and they are free of cost for women. But it's their free choice.
Got it. Thank you.
Finance?
Nothing to add. John Butch, Department of Finance, nothing.
Thank you. LAO?
We didn't raise any issues with their estimate.
Excellent. Public comment, please.
Hi, Justin Garrett with the March of Dimes. We're a lead advocacy organization for newborn screening and support the important work of the genetic disease screening program. With regard to specific conditions, we support requiring newborn screening once a condition is added to the recommended uniform screening panel, given that ALD is moving forward in the process and that the AB 1559 requires it to begin as soon as it is added to the RUST. We do support the budget change proposal to get the funding to ramp up for that screening. Thanks.
Thank you. And just the remote chance that it doesn't make it through the screening process, what the department would do what with the identified resources? So
our plan at the moment is that we are making these computer changes and we're sitting them on a hold until they're ready to go. If for some reason something happens between now and they're never going to add ALD, we've been told by our RT people that we can retrofect those changes and change them to whatever next disorder is going to come along, and we always know there will be something new.
Okay. So some of it will just be investment in the computer
Investment, exactly.
Okay, we're going to hold this item open. Thank you very much for your time today. Moving on to item number 9, food safety inspection, page 48. Good afternoon, and we're looking to hear an overview from you today on the issue. Good afternoon.
Good afternoon, Senator Mitchell, Senator Monning. I'm Dr. Mark Starr, Deputy Director for Environmental Health in the Department of Public Health, and I have with me Maydan Klein, who's the Assistant Deputy Director in our center. Thank you for the opportunity to provide an overview of the next 5 budget proposals. Our center has the next 5 on your agenda. I'll first provide a very high-level overview of our center. I know time is short, and then I'll provide a brief overview of each of the 5 proposals. The programs and expert staff in the Center for Environmental Health work to protect and improve the health of all Californians by ensuring the safety of food and drugs, medical devices, by conducting environmental management programs, and by ensuring the safe use of radiation in California. We do this through investigation, inspection, laboratory services. We have 2 laboratories in Richmond, regulatory activities, and also emergency response, a number of emergency preparedness activities. The programs with proposals before you today include the Food and Drug Branch, the Environmental Management Branch, and the Drinking Water and Radiation Laboratory. I'll begin with the Food and Drug Branch, which has the first 3 of the 5 budget requests. And I'd also like to compliment your staff for the excellent write-ups in your agenda package, which will allow my comments to hopefully be brief.
We've given her some M&Ms to thank her for all of the work that everyone talked about, so she's been duly thanked.
I'll make sure I bring some next time.
Yeah, please. For the chair, too, don't forget.
We won't.
I actually prefer Jolly Ranchers, but you know. Our first request is issue 9 on your agenda, and it's titled Food Safety Inspection, as you noted. Our Food and Drug Branch's role includes conducting statutory mandated activities and inspections of food processors and distributors in order to ensure food safety and reduce foodborne illness in California. This request is for 6 permanent positions and $804,000 authority from the Food Safety Fund, which is a special fund created through the receipt of registration fee revenues. And this is in order to meet these responsibilities. It's a workload-based request, increasing field staff from the current 17 to the needed 23 positions, and no increases in fees are being requested. Business is good in California. The economy's been improving, and there have been an over 60% increase in the number of new registration applications for food processors and distributors over the last 5 years. And the inventory of existing registered firms has dramatically grown as well. However, staffing levels have not kept pace with the new workload generated by these increases. So the impact of these 6 new positions will be significant. Our program will be able to meet statutory mandates and to ensure that new businesses are registered and become operational as expeditiously as possible. We also will, of course, allow us to continue to provide a high level of protection of the food supply in California. Any questions on this item?
None here. Finance?
No.
LAO? Go to your next item, then I'll open it up for public comment.
The second request is also for our Food and Drug Branch. It's entitled Food Safety Stipulated Judgment Appropriation. Part of the role of our Food and Drug Branch and food safety includes ensuring safe storage and transportation of foods, including appropriate sanitary conditions and temperature controls to prevent the growth of microorganisms. These aspects of our program are currently food processing are currently evaluated at the location of processors and distributors during facility inspections and response to complaints, but not generally out on the road, so to speak. In July of 2013, in response to a referral from a news organization, our Food and Drug Branch investigated Cisco Corporation and found extensive improper transportation and off-site storage violations. There were over 1 million specific violations after a 4-year review. This led to a civil complaint and a stipulated court judgment. 3.3 million of that resulting settlement can only be spent by the Department of Public Health for purposes of conducting food safety, transportation, and enforcement activities. And these activities also provide an opportunity to better address this area of food safety without increasing fees. So the request is for 4 5-year limited term positions and authority to use $716,000 of these settlement funds in the first year and somewhat less in ongoing next 4 years in order to implement the food safety, transportation enforcement activities resulting from this court judgment. We're also requesting approval of trailer bill language to amend the Health and Safety Code to allow the deposit of such funds into the Food Safety Fund. The proposal will provide the necessary resources for the Food and Drug Branch to further investigate distribution practices and to ensure that companies are protecting food throughout the distribution chain. I'll get to the second question that you had besides the overview, which regards what happens after 5 years, basically. Our plans for these enforcement activities after this funding expires will depend on our findings over the next 5 years. We'll see what problem areas that we identify, what industry practices improve during the course of those 5 years, and the likelihood of those changes being sustained over the long term. Evaluation of that information will drive our recommendations for any future investigation and enforcement activities that will follow this 5-year period. Questions?
Monty, anything?
No.
Any public comment on the inspection and stipulated judgment appropriation items? Okay, we're going to hold both of those items open. We'll continue on with the tobacco retail inspection.
Yes, so this proposal also is with our Food and Drug Branch, but it's a different unit and activity, not related to food, of course. The request is for 9 limited term positions and a little over $1 million in additional reimbursement authority for the remainder of our department's contract with the Federal Food and Drug Administration in order to conduct stake activities in California to stop tobacco access for kids enforcement program. Our role is to inspect retailers in California. We've been doing this since 1995, but since 2009, as a result of federal law, the federal FDA was required to contract with states to conduct youth tobacco enforcement activities. FDA's new 3-year contract, effective this past October, funds expanded activities that will accomplish retailer compliance checks of 20% of California's 37,000 licensed tobacco retailers each year. So the requested 9 positions and reimbursement authority will allow our department to fulfill FDA's contract expectations and the workload that is necessary to hit the 20% of those retailers. And of course, in addition to increased compliance, enhanced CDPH presence in retail establishments will increase awareness regarding tobacco use by minors. Perhaps most importantly, stake enforcement activities reduce the illegal tobacco sales to minors within California, making young people less likely to use tobacco, reducing nicotine addiction that often starts at younger ages, and reducing associated chronic illnesses, decreasing mortality, and decreasing healthcare costs. Any questions on this proposal?
None for me. Yes, Senator Monty.
I'm just curious, does this include now scrutiny of sale of vapor products, the vape pens, and they carry tobacco and they're sold at retail outlets?
Yeah, that's an excellent question. Vaping or e-cigarettes. This does not include that at this time, and the FDA is not currently providing funding to look at e-cigarette sales. This is just for youth tobacco sales, combustible.
Is there any, what's happening at the federal level? Is there any prospect that they're going to include the e-cigarettes?
I don't know about the funding. I know that FDA is a court decision, and my colleagues that will follow us actually know more about the tobacco program, but court decision allowed FDA to get into the arena of regulating e-cigarettes as well as tobacco products. But I don't know what that'll end up as far as funding for stake type of enforcement activities.
We heard at a hearing recently that there's now 3 times the use of e-cigarettes by teenagers than traditional tobacco products.
We heard that earlier today.
Was that today?
In public health.
It felt like yesterday.
Yes.
We've been here for a while.
Yes, we have.
Yeah. Thank you.
Yeah, I think our Chief Deputy Director mentioned that in his opening comments.
Thank you.
You probably heard it more than once. It's okay.
Yeah.
You did.
I was accurate.
Right.
Keep repeating that statistic.
It's
good
worthy
message.
of repeating,
Yes.
tragically. Finance or LAO? Okay, is this the last one you're presenting on, or are you doing the
I
next
have 2
one?
more.
Tomorrow.
2 more? Okay, we'll continue to roll through, and then I'll add, we'll have public comment after the inspection of the public beaches. So medical waste resources.
So this request is for 3 two-year limited term positions and $330,000 of authority from the Medical Waste Management Fund for the next 2 fiscal years to implement mandated provisions specified in AB 333, which is chaptered last year. This bill provided updates to the Medical Waste Management Act, ensuring public health protection for the proper transportation, temporary storage, and disposal of medical waste. This was actually the first major update of this Medical Waste Management Act in 23 years. In order to protect workers and the public from inadvertent exposure to pathogens and medical waste, our department's Medical Waste Management Program, which is located in our Environmental Management Branch, enforces the Medical Waste Management Act. It's accomplished through oversight of all aspects of medical waste, ranging from the generation and handling all the way through to the actual treatment and disposal. Because federal law, via the Department of Transportation, also governs the transport of medical waste on public roads, AB 333 requires our department to convene stakeholder meetings and submit a report to the legislature describing the interaction of federal and state law in this regard. That report has to be submitted no later than January of 2016. In addition, because the Department of Transportation allows a party to petition for a preemption determination when there is a conflict between state and federal law, the legislation allows our department to temporarily waive the bill's requirements if a determination is pending. And lastly, the bill authorizes our department to update standards related to the transportation of medical waste through the issuance of guidance documents. So the requested positions and expenditure authority will allow CDPH to perform the workload associated with AB 333 implementation over the 2 years, including a number of activities, conducting stakeholder meetings and preparing the report that I just mentioned, developing the guidance documents, training sessions, preparing preemption documents, waiver requests, and so on. Some of this workload is a request of the August amendments to the bill. In summary, these activities will assist the healthcare and medical waste industries with compliance with the Medical Waste Management Act and further the protection of workers and the public.
Finance? LAO? Senator Monning? Okay, thank you. We'll move on to inspection of public beaches resources, SB 1395.
So our last request is for 1 position, a 3-year limited term position, a microbiologist to work in one of our laboratories, and for $384,000 of general fund in the first year and $182,000 thereafter. This is to implement the mandated provisions of SB 1395, which was also chaptered last year. SB 1395 authorizes the department to allow local health officers to use a departmental approved rapid testing method as the single test for contamination of beach water under specified conditions. This bill also authorizes the department to develop testing methodology and guidance for alternative beach water quality testing and to validate site-specific uses of the testing method. So I'll get a little more detail to explain some of that. This is a little more complicated endeavor. But for beach water quality safety and the big picture, local health departments are charged with the sampling and testing of the water and posting or closing beaches when it's necessary to protect public health if they find something in the water. The current permissible tests are culture-based methods and tests for 3 indicators: total coliform, fecal coliform, and enterococcus. These have been in place for a number of years, mandated legislation in '97, and I think some of this testing for coliforms dates back to a couple of years after I was born. The role of our state laboratory, the Drinking Water and Radiation Laboratory in this arena, is to develop and evaluate test methods for water quality. The United States Environmental Protection Agency recently released methods for a rapid test called qPCR for the detection of enterococcus in recreational water testing. And enterococcus is one of the 3 indicators that I mentioned earlier. Without getting into too much detail, PCR stands for polymerase chain reaction, and this is a method where the DNA of an organism is amplified with an enzyme called polymerase, and then it's detectable by lab testing, and it's a method that doesn't require culturing an organism. It's very complex. It's susceptible to potential technical challenges such as cross-contamination, and interfering substances can make it so that it doesn't work sometimes, but it has an excellent turnaround time when compared to culture. 4 hours for these rapid tests compared to often 2 days for culture. The Environmental Protection Agency, while releasing these methods, they left it to states to develop guidelines and criteria for implementation of qPCR. So I'll share with you now just a few of the challenges with implementation of qPCR for beach water testing that make the requested work in our state laboratory essential to assist local implementation of this testing and to protect public health. First, there are no approved qPCR methods for use at saltwater beaches. While EPA published these methods, it's really a series, latest in a series of research methods. And this is really an active area of research in applying these methods to recreational water quality. qPCR technology for beach quality monitoring is still evolving rapidly because of this research. And the success of the method varies by beach type, whether it's a bay, open coastline, lagoons, things like that. And also it varies by the specific sample location. And work that's been done to date, agreement between culture and qPCR can range from 67 to 85%. But the scientific basis of that, the acceptable level of correlation, when we go to look at how does qPCR compare to culture, and evaluating side-by-side testing still remains to be determined. qPCR is subject to false positives and false negatives. I mentioned some of the cross-contamination issues as well as some interfering substances that can occur, and those contribute to those challenges. And of course, false negatives, which means that a test fails to detect that there's a pathogen in the water, is our biggest public health concern, so makes it important that we validate these methods. These interfering substances can also vary with the tides, with runoff and waste discharges, and of course by location and by season. So site-specific validation is also a component of implementing these methods. And of course, qPCR only detects Enterococcus, which does account for about 90% of beach water violations, but not all of them. In short, qPCR is not yet a reliable and well-established practice like conventional culture-based methods, but is very promising for rapid testing. There are currently no California laboratories certified to conduct this testing, and the state program that is responsible for accrediting environmental laboratories, which is the Environmental Lab Accreditation Program, located in the Water Board, does not have experience with such assays, so they're not able to certify labs at this time. So our department needs to develop the expertise to utilize the new qPCR test procedures. We need to develop the methodology and guidance documents. We need to develop validation and quality control criteria. We need to be able to do site-specific testing and side-by-side training materials, checklists, and also prepare the Environmental Laboratory Accreditation Program in order to be able, for them to be able to certify laboratories for this testing. And of course, as this goes on, we will provide consultation to local health departments that wish to implement this method, and we'll review the side-by-side testing results that local jurisdictions have when they prepare to implement it. So this essential work by our state reference laboratory will enable local health departments to consider the use of this new and complex rapid testing method for beach water. It's an alternative that's expected to result in more timely determinations of public health risks and shorten durations of beach closures. For those of us that grew up in Southern California, that's very important. Any questions?
None for me. Finance? No. LAO? Any public comment on the last 5 items? Okay, seeing none, it's a staff recommendation that we hold all of these items open, and we'll do that. Thank you very much for your time today.
Thank you.
Appreciate it. Moving on to item number 14, second to the last item we'll take up today, California Gambling, Education, and Treatment Services. CalGETS. Is that the way we pronounce your acronym? All right, CalGETS, page 55 on the agenda. Yeah,
good afternoon,
right.
Senator Mitchell.
Good afternoon.
Good afternoon, Senator Monty. And I'm Dr. Kevin Sharon. I'm the Deputy Director for the Center for Chronic Disease Prevention and Health Promotion for the California Department of Public Health. And the Office of Problem Gambling is one of the programs that we have in our center. So I'm very pleased to tell you about the CalGETS program. And this has been a pilot program in 4 regions of the state, and it has been funded for 7 years continuously with intermittent allocations over that time period. Now, this year we have a budget change proposal to make this program permanent. It's certainly been established that there are a significant number of problem gamblers in the state. And so you have some trailer bill language to accommodate for the fact that we have, problem gambling treatment now being added as a component, and updating the language to the current guidelines for the medical evaluation and treatment of problem gambling. The Indian Gaming Special Distribution Fund seems to be adequate to sustain this program into the future, and if it's not funded for 2015 forward, the program would just simply come to an end. So we're asking for 2 positions at the state level. There's a total of $5 million proposed, and $1 million would be for the state office and its operations, and $4 million would be for local government, local community-based services. And that, by the way, the acronym Cal gets is the Gambling Education and Treatment Services. So in the past, it's been prevention only, and in the recent pilot, it has added the component of treatment. So the idea is to take the pilot now and to make it into a permanent program. And I'll be happy to answer any questions on the CalGets program.
Based on the research done historically, this may be really an elementary question, but is there any correlation in terms of the number of people identified in the state as problem gamblers with the expansion of legal gaming activities?
There does seem to be some correlation, and I can't give you the exact numbers, but the program came into being with the legalization of gambling in the state at its early inception. And yes, there does seem to be some correlation as the number of gaming,
Establishments.
Entities, yes, establishments increase. That yes, they do have an increase in the volume. In fact, they're up to 13 calls per day on average to the 1-800 problem gambler line at the state level.
And there's numerous pieces of legislation introduced every year to attempt to kind of break through the discussion around online gaming. Has this program done any research nationally in other states where that's taking place currently?
I'm not really aware of that, okay, Senator, and we can get back to you.
No, you don't have to. You don't have to. I was just curious, as I know the conversation is going to continue in this body. Right. And if there was a correlation, right, because it could have a direct impact on your program.
Our assistant deputy has an answer to that question, okay, Senator.
Good. Madam Chair, Greg Oliva, Assistant Deputy Director, Center for Chronic Disease. We have done a little bit of research. There's some legalized online gaming in, I want to say New Jersey, a few other states. What we haven't found from their experiences to date is a dramatic upheaval or increase. Okay. But I think you need to make a distinction when we talk about that. There already is a lot of illegal online gaming. True. So I don't think there's a distinction made in the surveillance or research that's done in states like New Jersey where that it's legalized. If somebody needs help or services, or there's any sort of efforts where a state like that can ascertain how many problem gamblers they have, whether they're doing illegal online gaming or they're doing legal online gaming. Got it. I think it's relatively flat. Gotcha. But it's something that we would want to continue to pay attention to with the variety of bills that are taking place within the state. Absolutely. Thank you for that. Senator Monty, any questions? Finance?
No.
LAO? Any public comment? All right. This is an item. I'm pretty sure we're holding it open. And yes, we are. Thank you. And our last item today, biomonitoring resources.
Yes, Biomonitoring California has been around for a number of years, and what we're asking for, Senator, is 6 state positions that would be funded at a level of $900,000 in the budget change proposal. And this is proposed to come from 2 separate fund sources. One is the Toxic Substance Control Fund, and the other is the Birth Defects Monitoring Fund. So the bulk of that is from the Toxic Substance Control Fund, $775,000, and $125,000 from the Birth Defects Monitoring Fund. And this program, its intent has been to look at the emerging chemical threats to Californians, and in particular, heavy metals, phthalates, pesticides, any number of different issues that have disproportionately affected some of our populations.
Yes. Yes, Senator Monty.
These, by the way, these are limited term funds.
Okay.
2-year funding.
How do you determine the distribution of those resources in terms of studying different risks in different parts of the state or caused by different chemical agents or other?
Well, that's a great question, Senator. And so that what they do is they tend to risk stratify the state according to a plan that was articulated some years in the past, and that they look at, you know, mothers and children as an example. They've had studies that have looked at phthalates that are in baby bottles or plastic materials. They've looked at areas that have had exposure to pesticides. They've looked at, you know, some children that have actually been exposed to these heavy metals and creams that they found, where they have skin lightening creams in the area around Stockton, I believe. They found, you know, adverse events happening, children actually having mercury poisoning from that. So they've gone where the money is, so to speak. They've gone where there are issues that have come to light, but they also do sampling in a way which looks at different populations in different parts of the state. And if a chemical concern emerges, then they look at that as well, and they try and make it part of their work plan. But the overall program has been trying to build laboratory capacity and assessment capacity to maintain a program, to have an ongoing biomonitoring program for chemical threats. That helps?
It does. Yeah, I think that's helpful. I could drill down on that a little bit, just the region I'm in. And I guess the final question, Ken, is the department with these resources responsive to either local health departments, or even what if there were a neighborhood or a citizens group concerned about clusters of birth defects? Is there a responsive mechanism in this, or is it just based on your risk strategy vectors around the state?
Well, there are different programs that actually come out of the Division of Environmental and Occupational Disease Control, which is based in Richmond. And Biomonitoring California is one of them, Senator. We also have the Environmental Health Investigations Branch. And as you heard, there are other programs that look at some of the maternal-child health issues as far as epidemiology concerns. But let's say the California Department of Public Health works collaboratively on those issues. So if we have a cluster that we hear about, we have a capability of doing analysis of data. That would be the first step. And then we would decide what assets we have that we can deploy to the local situation. And yes, I know that the department is responsive and goes into communities and follows up in a very meticulous way, given the resource allocations that it has. And certainly this is one of them. Biomonitoring California is one of them. And each year they can look at what they can do as long as there's funding. This is only 2-year limited term funding.
Thank you. That's helpful. Thank you.
Excellent. Finance?
Nothing.
LAO? Any public comment? Thank you very much. We're going to hold this item open as well. Thank you, everyone, for sticking with us in the deep freezer. When's our next sub-3 hearing? Our next sub-3 hearing will be a week from today. Thank you very much. We stand adjourned.